it's raised. Then it progresses to vesicles, for which the regular term would be blisters, which is why it can be confused with chickenpox, for example. Chickenpox also appears as blisters on the skin. Then it progresses to pustules, so these little blisters can begin to fill with a whitish fluid that looks like pus, and so they are called pustules. After that, they begin to dry and scab, and after that the scab falls off. That is the classic progression of the rash. In terms of the body itself, the classic progression is face and then to limbs, palms of the hands, soles of the feet, and then to the body itself. That also is a classically described progression. Another classic picture from monkeypox from past years is the swollen lymph nodes. You might recall that the World Health Organization and all countries of the world eradicated smallpox, and the eradication of smallpox was declared in 1980. And so that disease no longer exists, to show that some things are containable even when they've been around for a very long time. The reason I raise this now is that at the time of eradication of smallpox, monkeypox had already been identified in people. 1970 was the first time. So we had a period of about 10 years when we had a little bit of both. And the distinction between smallpox and monkeypox was the swollen lymph nodes. If a child had swollen lymph nodes, it was more likely to be monkeypox than smallpox. So these are some of the things we know already, because countries that are familiar with this infection, this infection that comes from the animals in the forest actually, they are familiar with this, and so this is what has been classically described for a long time. What we are seeing today, still we have that picture, but we also have a higher proportion of cases where the rash may begin a bit more locally and it may remain a bit more locally. Possibly because of the nature of the contact, again we don't know, but we're seeing more cases where the rash begins in the genital area, which is not new, that has always been there, but it's more frequent now, and sometimes it tends to stay there. So it's also possible that the rash may not be visible because it may be covered. If it doesn't reach your hands or your face, then it may not be seen. However, it does remain important to consult your healthcare provider, because that rash can even contaminate your bed sheets, your clothes, and so on. And so you don't want to expose people in your family, for example, or your other social contacts to contaminated materials, which is also one way in which monkeypox can spread.
Brings us on to another question. I think it fits in well again. So we've been saying right off the top that not everybody's at equal risk, and in communities where there are people, in social networks where there are people with monkeypox, those who are most at risk are their close friends, their close contacts, their family members as well. Historically, you mostly saw monkeypox would spread between family members and also sometimes health workers who are helping those people. So here's a question from Vasiliki Angoridi, and this will be for you, Andy. Saying, can you please elaborate more on the MSM comment, because many officials have considered that a rushed, superficial approach that only fuels discrimination. So just talk a little bit again, maybe even just again, why you're with us and why we're having, for now, an inclusive approach, focusing in part on men who have sex with men, but as Dr. Van Kerkhove explained earlier as well, we're also asking countries to look in dermatology clinics, primary health care, and elsewhere to see if they can find further cases of monkeypox. So that was a very big preamble, but just wanted to pass back to you, Andy. Can you explain why you're here and why we have special concern and working especially with communities of MSM?
Of course. So yesterday we issued some interim public health guidance for gay, bisexual and other MSM, and it really tried to answer the question you just posed to me, essentially. And really one of the things that we've, again, it's early days and we don't have all of the information yet, but this demographic is generally a demographic that really does take care of health screening when it comes to potential STIs. So for example, we know that MSM, if they do spot an unusual rash, they're likely to want to get it sorted out quite quickly. So they'll want to go and seek health advice. They'll want to access an STI clinic if they have services in their local area. And so the fact that they've been proactive about responding to unusual symptoms might be part of the story. And again, more of this will really become clearer in the weeks and days to come. So I do think that could definitely be part of the story. Similarly, I think the classic thing here is that, we have this atypical outbreak. It has been widely reported in the mainstream media in a number of countries. Sometimes the reporting is very good. Sometimes it does come, sadly, with some misinformation, stigma and discrimination, not only about the MSM community, but perhaps also unintentionally suggesting that this is an African disease by only using images of black skin, for example. And so there are ways that we can work with communities to learn from really decades of experience around tackling stigma and discrimination with HIV. We want to apply those lessons learned to this experience. And again, we work very closely with colleagues on COVID as well around the same issues. How can we make sure that communities are helping inform messaging, helping us with the surveillance around myths and misinformation, collectively directing people to trusted sources of information, and really encouraging people to act appropriately, responsibly, and really do their very best to find trusted sources of information and advice.
Can I come in on that one? So in addition to what you've described here, I think we need to, when we respond to something that looks different, it looks new for whatever reason, as public health professionals doing an outbreak investigation, we need to describe what we see, right? We describe what we're learning. It's not to say that we know everything. It's not to say that we know what's going to happen tomorrow. But today we need to describe what we're seeing, and where we saw the first cases are one of the indications as to why this perhaps is a different situation from what we've seen before with monkeypox. So it's not about discrimination. It's not about stigma. It's about saying, where are you seeing the first cases? How can that help you do contact tracing? How can that help you with the investigation to go and find out perhaps a different type of source to begin with? But where is it spreading now, and how is it spreading now? These are questions we ask ourselves in the middle of an outbreak investigation.
I know colleagues have said that repeatedly. We're basically describing what we know now, and we share more information as we get it. So a couple of administrative things. I said this in the first intro and didn't say it in our second intro. Why are we not wearing masks? We're a little bit closer together than you've been used to seeing, for example, Dr. Van Kerkhove and Dr. Mike Ryan in their Facebook lives. We're in an open space. We always say try to be in open spaces as much as you can. There's more air circulation here, so that's good. We have our masks. We're just not wearing them now. We would wear them if we were in closer proximity. We've all been vaccinated, and as part of this health assembly, everybody is meant to do a COVID test every morning and only come in if their tests are negative. So we've all done that as well. Another administrative thing, I know a lot of our journalist colleagues are watching us here, but these Ask WHO Lives are for the general public. Please write to us on the email address that you know so well with your questions. The box is being monitored as it always is, and we'll get back to you that way. And we've seen you have a couple of questions for us, but we generally aren't answering media questions through this platform. This is really for the public. And Dr. Van Kerkhove, I want to go to you next. What is WHO doing about this? We've touched on a few things, but can you give us the overview of what WHO does, not just in a situation like this, but in this situation?
I can, and then I'm going to ask Rosamund to supplement, because there's quite a lot of activities that are ongoing. I mean, one of the things we really need to do right now, I mean, we're working with partners. We'll always work with partners and scientists and technical colleagues all over the world, but we have some major areas of focus that we are working on right now, and we are working with member states to achieve these things. One is we have to raise awareness about what monkeypox is, what it isn't, and we have to expand surveillance. So particularly in countries that aren't used to seeing monkeypox, we need to equip ministries and governments and countries, health clinics, to be able to recognize what monkeypox is and to ensure that people who may be suspected as having monkeypox get the appropriate clinical care. We want to stop human-to-human transmission. We can do this in the non-endemic countries, and this is really critical because we're in a situation where we can use public health tools of early identification, isolation of cases, supported isolation of cases, talking with communities, listening to communities, engaging with communities to be part of the solution. This is not about WHO telling the world what to do. It's about working with communities to say, how do we come up with solutions that fit in this? But I do want to reiterate that this is a containable situation and we can stop human-to-human transmission. We also want to protect frontline workers. Anyone that's out there that's taking samples to do testing or to care for individuals, we want to make sure that they have the right information, they have the right personal protective equipment, and we want to utilize all of the countermeasures that are in place. There are some antivirals, there are vaccines, but we have to utilize these most appropriately for those who are most at risk in an equitable fashion. And again, lastly, overarching is to advance our understanding about what monkeypox is. So we're going to be having a big global meeting around R&D, research from everything from the epidemiology all the way through diagnostics, therapeutics, and vaccines, and that'll be happening next week. But Rosamond can supplement that because there's so much other activities that are actually happening there.
I think you've covered a lot of it, Maria. One addition that we could offer is that, as you say, we work with experts around the world on a regular basis. You've mentioned it as well, Andy. And so what they help us do is draft the guidance. So we have materials online. Some of you may have already looked at the training materials that are already on the OpenWHO platform. There is an introductory course there. There's also an intermediate course there that really takes you through quite an extended course of 2.5 to 3 hours, and if you set aside a little time and you want to do that, you can learn a lot about monkeypox. Anybody can do it, it's free, you'd register on OpenWHO platform, but it's free and anybody can do it. I would like to mention that course was prepared over the last couple of years, and it was released in January of this year, right before this event has now become apparent in May of 2022. So you'll see that the information was really targeted towards health workers in the Democratic Republic of the Congo, in Nigeria, Central African Republic, and Cameroon. This was our target audience for that training. So don't be surprised if you see that the voices, the sounds, the images, the pictures are designed for our target audience. Now we're very happy that you're going to be looking at these, but don't think that we just made up this course yesterday, because it really has taken some effort, and we're going to continue to make that effort to provide information. In order to do that, we will also draft guidelines for health authorities around the world, so guidelines on surveillance and contact tracing and isolation, guidance on laboratory, guidance on communications. This target audience is different. This target audience is for the ministries of health of our member states, and so it will go at a different level. They will also be available online, and you will also be able to look at them. But for every product that the WHO produces, there is a different audience, isn't there, Nika? And so this is what we try to do. We try to tailor the messages and the audiences, the products and the materials for you. And it's a tremendous privilege to be here today with you, the public, and to answer your questions. And we do the same for different audiences, including our member states' ministries of health.
That's another example of the ongoing work WHO had already, but I've heard you say this already, Dr. Van Kerkhove, in previous settings. There hasn't been enough work on monkeypox. There aren't widely available vaccines, there aren't widely available therapeutics, and yet there are people who experience this painful, unpleasant, and in some cases deadly disease, and more needs to be done. And perhaps this is an opportunity, now that the world's eyes are focused on this, that some of those things can happen. I have a question from @Aura03113 asking, is it true that the smallpox vaccination can protect against monkeypox as well? And even if that vaccine was received a long time ago. So we know some information related to that. I'm not 100% sure, but I think that's back to you, Dr. Lewis.
Right. So of course, there was smallpox vaccines available, and those contributed tremendously to the eradication of smallpox. At that time, it was learned that, it was observed, and studies were done, that the smallpox vaccines used at that time were protective against monkeypox about 85% of the time. If you've been following, of course you have been following vaccine efficacy information around COVID and other diseases, you'll know that 85% is not perfect, but it's also not terrible. And I would also add that this is a vaccine effectiveness that is attributed to the older vaccines, and we now have new vaccines, because although smallpox was eradicated, research has continued for the last 40 years, and people were wondering why. Well, this might be a good example of why, that these viruses are closely related to each other, and now we have the benefit of all those years of research in diagnostics, in treatments, and in vaccines that will be brought to bear upon the situation now. However, Because these are relatively newly discovered products, they are not yet widely available. They are available to some ministries of health in national stockpiles, but they're not yet widely available commercially. So another area of work that we'll be engaging in will be to work with partners and the commercial and sector and industry to see what we can do now to enhance availability of these products.
Because I think we have a real opportunity here. You know, as Rosamond has described, there are products that are available, but they're not widely available yet. And we have an opportunity here to use these appropriately and to use these for those who are at risk. So we will be making recommendations on who, you know, should be prioritized for this. This is not something that everybody needs. It is a virus that is spreading between people who are coming in close contact with those who are cases. And we really need to discuss, you know, evidence-based use of these measures, access, and equity. We really, as a global community, have another opportunity to do this right. And so what we want to make sure, and we are going to be working really hard across all of our partners, whether it's from manufacturing or whether it's from our ministries of health and whether it's the general public, to make sure you understand what the risk is. And we will be doing these regularly, you know, and inform you about what the risk is. And if the situation changes, we of course will issue information through all of our channels to member states and to the public. But we have a real opportunity here, and I couldn't let that go. Just given the situation that we've had with COVID-19, there are some parallels in terms of access, and this is really important.
Communities are already saying to us, you know, if we get this right, if we contain this, if we get the access right for the outbreak, we have to do this for the endemic countries as well. You know, and I think this is where the opportunity is coming in, you know, and the communities have already spotted this, they're already talking about it, and it's something that I think is definitely part of our intended approach.
Thank you. And with that, we're going to wrap up. We haven't answered all your questions, but we do see and hear your questions, and we fold the answers into our speeches, into our Q&A, into the products we put out on social media platforms. So continue to ask those questions. That helps us know what you need to know. If we're not communicating something clearly, we help by seeing if your questions show that confusion as well. So do keep giving us your questions through #AskWHO. I want to thank our experts for being with us today. We had, at the end of the table, we had Andy Seal, who's with the WHO program on hepatitis, HIV, and STIs, that's sexually transmitted infections. Thank you very much. Somebody noted there was actually a neat comment from somebody saying that you were totally right. It's because MSM are extremely good at checking themselves that we have part of this signal. So thank you for being with us, Andy. We have also Dr. Rosamond Lewis, who's the head of the Smallpox Secretariat in WHO's Emergencies Program, and I think maybe you understand a little bit more about how smallpox and monkeypox are related now. And lastly, we have the most familiar face of all, Dr. Maria van Kerkhove from the Emerging Diseases and Zoonoses program within also the Emergencies Program. Thank you all very much. See you next time.